Our next speaker is Daniel Sanderson from Madrid, who will be talking about his work on the diffusion and reconstruction media for multiple artifact correction in CT. So take it away.
So hello everyone. I'm going to present our work on variational diffusion reconstruction for multiple artifact correction in CT imaging, sort of continuing with the previous talk. So I want to thank all our collaborators from UCL who have really made possible this project. So, well, let's start by presenting the motivation of this project. Well, basically, the idea is that in veterinary clinics, we have budgets and space limitations. So we cannot really introduce a whole clinical CT system because they are usually very large and they do not really fit into small clinics. And besides, CT systems usually have closed gantries, so it's difficult for the veterinarian to really access the patient during preparation of the image acquisition. So therefore, we require solutions in order to really allow their usage in the clinical practice. However, currently available solutions do not really assess all the needs that are currently required in the veterinary clinics, and therefore it will be of interest to have a compact multimodal system that incorporates X-ray, planar X-ray, fluoroscopy, and CT systems using an open gantry, so we can really allow the veterinarian to access the animal. So currently, this is what we are doing at my university in Madrid in collaboration with the industry. We have developed a system that basically incorporates planar X-ray, fluoroscopy, and CT. And given the configuration, the hardware configuration of the system, what we have is a cone beam geometry for the CT acquisition. So this means that this is an implicit 3D reconstruction problem. And also, as we have an open gantry, a C-arm, this implies that the reconstructed images will have geometrical distortions due to the limited span angle, and also streaks appearing due to the limited number of projections that we acquire in order to reduce the dose that is applied to the patient. There are many other artifacts, and in fact, this is what I've been working at in my PhD, but at the moment we're just going to focus on these two main artifacts. So, well, I mean, in these last sessions we have been already seeing this. But, well, just to say that these two types of artifacts have been widely explored in different works along the literature. And right now, state-of-the-art is given by hybrid methods, as we have already seen, and that basically use diffusion models as high-resolution priors and combine them with model-based inverse reconstruction methods to impose data consistency and reduce the appearance of hallucinations. So for this type of application, I'd like to distinguish between two types of methods, gradient-based and not gradient-based. Gradient-based are faster, so more interesting for our type of applications. And non-sampling methods, we expect them to introduce a better consistency, data consistency, because they do not really apply the generative pipeline of generative models, as we will see later on. So current limitations of some of the works that we have seen in the literature, well, most of them do not accomplish one of these conditions. So maybe some of them only address 2D reconstructions, or they do not focus on fast inference times, or in some occasions they only focus on a single type of artifact. And therefore, in our project, what we intend to do is to develop a reconstruction algorithm that allows to, well, correct or obtain these artifact-free images, accomplishing the following requisites. So that is fast, that is robust for multiple artifacts, that reconstructions are really consistent with the data, so there are no hallucinations appearing, and that is compatible with 3D reconstruction. So at the moment we haven't, this is a preliminary work, so we haven't actually gone into 3D reconstruction, but we believe that this method is going to be actually compatible with it. Okay, so what we propose is using the solving the optimization problem proposed by RedDiff, which is a non-gradient based method that allows for faster reconstructions a priori, and also it's a non-sampling method that only uses the diffusion model as a regularization term within the optimization problem. And we propose solving this with ADMM compared to the original solution that they use Adam. As it's simpler, we believe it's simpler to decouple the data consistency and regularization terms into two different and independent problems, so we can appropriately balance each one of them as we prefer. So basically, the optimization problem that we're trying to solve is obtained by a variational approximation of the posterior distribution, which is optimized just by minimizing the Kuhlmann-Leibler divergence that allows us to obtain a data consistency and regularization term, which we can further simplify to a traditional model-based inverse reconstruction problem just by applying the Usner's theorem and allowing us to obtain a regularization term where the diffusion model is just incorporated as part of this regularization term. So the good thing about this method is that we don't have to compute the Jacobian of the diffusion model. So in order to compute the gradient of this regularization term, we just it can be simplified to the expectation of the weighted difference between the noise that is added to the reconstructed image at each iteration and the prediction of the diffusion model for that noise. Okay, so what we can do is to split this problem using two primary variables and impose the constraint using the augmented Lagrangian. And in this way, we can split it into three subproblems. The X subproblem, which is the one we are interested in, we solve it with the conjugate gradient because it's the fastest for linear systems, for convex problems, such as the one that we have for this X subproblem. And for the Z subproblem, which is our second primary variable, we solve it with a single step of the stochastic gradient descent method, given that in order to perform each iteration, we will have to reevaluate the regularization term, and therefore we have to perform reinference of the model, which is slow in our case, so that's why we use a single step. The good thing about ADMM, compared to the methods such as HQS, for instance, is that the feasibility, the primal feasibility of the solution does not actually depend on hyperparameter scheduling, only on the Lagrangian, and therefore it won't enter in conflict with this type of weighting that we are using here, which was the case, for instance, of other methods that we have tried. Okay, so we evaluate this, this proposed reconstruction method with a publicly available dataset with CT rate, with 40 clinical patients, and then we also evaluate it with a veterinary patient acquired with a clinical veterinary system. We simulate our artifacts with the Astra Toolbox, so it's PyTorch compatible, so it's pretty fast. And we apply a polychromatic spectrum to really perform a realistic simulation. And then we compare with a supervised method that we call Deep Parquet, post-processing domain, sampling diffusion such as DDS, as we saw yesterday, and with the original RedDiff implementation, just to ensure that we are improving the results. So what we can observe is that we really have a primal and dual feasibility, so we have a convergence of our method, despite having this stochastic regularizer. Then we also observe that when evaluating the hyperparameters of our problem, that there is a low variability in performance for the appropriate choice of hyperparameters. So in theory, it should be applicable to a large range of patients, so it shouldn't be patient dependent when transferring this into the clinical system. We also observe that we have an improved performance for multiple iterations of the X problem, meaning that we are really benefiting from using this type of splitting method. And then that we also obtain an optimal balance between performance and reconstruction for around 100 inference steps compared to the 1,000 steps that the original implementation required, so we can really speed up our reconstruction. Okay, so let's start by checking or analyzing results on the clinical images. If we adjust window width and window level, so the intensity and the contrast of our images, as is usually done in the veterinary practice, or in general in all practices, we can observe that DDS, although it provides like the nicest looking images, it actually is introducing false textures within the lung, sort of more slight hallucinations that we don't really want, while the RedDiff, both for the original implementation and the ADMM solution, we observe that it's capable of recovering structures without introducing these sort of false positives within the reconstructed images. If we evaluate a second patient, and this time we look at the region corresponding to the limited span angle geometrically distorted region, we observe that the anatomical information is recovered, especially for DDS and ADMM RedDiff. But as we said before, we are not introducing false positives, we're not introducing hallucinations into our image, and therefore is more data consistent in that sense. Well, here we can see it better, sorry. Okay, and the real difference arises when we evaluate this in out-of-domain data. So in this case, on the veterinary images. And we can observe that, especially in this geometrically distorted region, the ADMM approximation is better capable of recovering the anatomical structures, especially compared to the rest of the methods. And this is likely due to the fact that we are imposing more data consistency iterations compared, for instance, to the original RedDiff implementation. And contrary to the sampling methods such as DDS, RedDiff is only using the diffusion model in order to guide the reconstruction. So the weight, so to say, of the reconstruction is not on the diffusion model, but on the MBIR, so the model-based inverted reconstruction model itself. And also, as we're performing less inference steps on the model, we observe that we can really speed up reconstruction time compared to the original method, for which we also tested it with only 100 steps, which is the same number of steps that we use in this case. We can assure that the results were not, the reconstructions were incomplete. So basically, what we have done here is just to solve the RedDiff optimization problem using ADMM. And we observe that in this way, we obtain results that have minimal appearance of hallucinations. And also, we obtain fast reconstructions thanks to this ADMM splitting. And for future work, we would like to really evaluate this on noisy scenarios. So at the moment, we are in a noise-free situation. And for that, we would like to likely approximate our Poisson noise with a weighted Gaussian model, so we can still continue to use the conjugate gradient method. Then we would also like to expand this to a 3D geometry, which we believe shouldn't be much of a problem, because we are thinking of different ways in order to perform random selection of multi-view slices, or perform patching, also to accelerate the model inference itself, so we can really accelerate the reconstruction. Then we would also like to compare with other methods that we have been seeing during this conference, in order to really evaluate out-of-domain performance, which, for instance, DDIP or SCD, for instance, and then finally evaluate this on real clinical tasks such as lesion detection tasks. So thank you very much, and that is all.
Thank you, Daniel. And are there any questions to our speaker?
I might have missed it, but on your last slide, you said your model gave fewer hallucinations. Is there a quantitative way of evaluating that, or are you just I haven't looked close enough to see them, because the measures we use, we've seen over the days, they don't tell us the least squares or whatever your loss function is. They don't really tell us whether there's a hallucination or not.
Yeah, that's it. I believe that's a very common problem in this type of tasks, how to really evaluate hallucinations. So we are working on that, actually. So at the moment, the metrics that we have explored do not really allows us to really identify these hallucinations. So this is something that the clinician can observe, can really, at the end, this is like a really subjective field, because what we want to do is apply diagnosis. We don't have a downstream task such as classification, segmentation, or wherever. So at the end, the primal sort of evaluation of this is visual, sort of subjective. But yeah, we're working on metrics that allows us to precisely evaluate these hallucinations, maybe using patch-based edge preservation index, or sort of a more perceptual quality metric or whatever. But at the moment, yes, purely preliminary work, purely visual, and yeah, I guess you cannot really see it from that back there, but you can really tell that there are textures there appearing. So yeah.
I think we are running out of time, so maybe you can take this later on. So let's thank the speaker one more time.